Welcome to the deep dive. Today we're tackling lung cancer, getting you the essential info fast.
That's right. We've sifted through the core notes, definition, types, causes, the whole lot.
Exactly. The idea is to pull out the absolute need-to-know stuff, presented clearly so it sticks. Think of it as your high-yield overview, perfect for getting your head around it quickly, maybe with those MSRA questions in mind.
Clear, concise, memorable. That's the aim.
Okay, let's dive in. Lung cancer. What's the basic definition we're working with?
So essentially, it's uncontrolled growth of abnormal cells in the lungs, forming tumors.
And the main cause. I think most people know this one.
Yeah, the number one trigger is long-term exposure to carcinogens. And, tobacco smoke is way out in front as the primary culprit.
Okay. And it's not just one single disease, is it? There are different types.
Precisely. We split it into two main camps. First, non-small cell lung cancer, NSCLC. That's the more common one, about 80–85% of cases.
And within that?
Within NSCLC, you've got subtypes like adenocarcinoma, squamous cell carcinoma, and large cell carcinoma.
Right. And the other type?
That's small cell lung cancer, or SCLC. Less common, maybe 15–20%, but it tends to be much more aggressive.
More aggressive how?
Well, it often spreads earlier and more widely. That means surgery is often off the table, and generally the prognosis is poorer.
Okay. And crucial point, both can spread, metastasize.
Absolutely. Metastasis is a major factor influencing treatment and ultimately the outcome.
So smoking is the big one, increases risk tenfold, you said.
Right.
What else contributes? What are the other risk factors?
Well, yes, smoking is the giant, but don't forget secondhand smoke. That's definitely a risk.
Okay.
Then you have occupational exposures, things like asbestos. That alone increases risk 5 times. Also radon, arsenic, certain industrial chemicals.
And asbestos plus smoking is particularly bad, right?
Yeah, that's a really nasty combination.
Yeah.
The risk jumps dramatically. It's something like 50-fold.
50, wow, 50 times. That's huge. Anything else?
Air pollution plays a role. And genetics, some people have a predisposition or a family history. Specific genetic mutations like EGFR can be involved, sometimes even in people who have never smoked.
Interesting.
Oh, and previous radiation therapy to the chest area can also be a factor.
Got it. And just to be clear, what's not a risk factor that sometimes gets mentioned?
Good point. Coal dust. That's not linked to lung cancer risk.
Okay. So fundamentally, what's going wrong at the cellular level? The pathophysiology.
It really boils down to genetic mutations. Carcinogens, especially those in tobacco smoke, damage the DNA inside lung cells.
Messing up the instructions.
Exactly. And over time, enough of these genetic errors accumulate, the normal controls on cell growth get switched off, and you get uncontrolled division. That's your tumor.
Does it happen the same way for NSCLC and SCLC?
The basic principle is the same, but the specific mutations and pathways can differ. You often see oncogenes, the accelerators, getting switched on, and tumor suppressor genes, the brakes, getting switched off. Plus, tumors need their own blood supply. That's angiogenesis. And they develop ways to hide from the immune system and, of course, to spread metastasis.
Okay, so moving on to symptoms. What are the sort of classic red flags people should be aware of?
Symptoms can be quite variable, depends on the type, the stage where the tumor actually is.
Yeah.
But common ones include a persistent cough, one that doesn't go away.
Like a smoker's cough that changes?
Potentially, yeah, or a new cough. Also, coughing up blood, that's hemoptysis, shortness of breath, chest pain, hoarseness, losing weight without trying, feeling really tired, and getting recurrent chest infections like pneumonia or wheezing.
Are there less common signs, things that might not immediately scream lungs?
Yes, definitely. Things like bone pain or neurological symptoms, confusion, seizures, weakness, jaundice, yellowing skin, fever. Finger clubbing is a classic sign.
Right.
You can also get swelling in the face, neck, and arms due to superior vena cava obstruction, difficulty swallowing, headaches, nausea, vomiting, sometimes a pneumonia that's really slow to clear up, loss of appetite, anorexia, or a condition called hypertrophic pulmonary osteoarthropathy, painful joints and clubbing, and swollen lymph nodes, often in the neck or above the collarbone.
And you mentioned something earlier, paraneoplastic syndrome.
Ah, yes, that's important. Sometimes the cancer cells produce hormones or other substances that cause effects elsewhere in the body. These are paraneoplastic phenomena.
Like what?
Well, you might see hypercalcemia, high calcium levels, or Cushing syndrome from excess cortisol, SIADH affecting sodium levels, and various neurological syndromes like Lambert-Eaton myasthenic syndrome, which causes muscle weakness.
That's quite a range.
It is. And the real challenge, unfortunately, is that early lung cancer often doesn't cause any symptoms. which is why, sadly, many people are diagnosed when the cancer is already quite advanced.
So if someone presents with these symptoms, or maybe something shows up on an X-ray, what's the diagnostic pathway?
Okay, imaging is usually the first step. A chest X-ray might pick something up initially.
But that's not definitive.
No, not at all. A CT scan is crucial, usually of the chest, neck, and upper abdomen with contrast dye. This helps see the tumor size, location, and if it looks like it's spread to lymph nodes or other organs.
Any other scans?
Sometimes PE scans or MRI scans are used for more detailed staging or looking at specific areas like the brain. But the absolute key for diagnosis is getting a tissue sample, a biopsy.
How's that done?
Several ways. Through a bronchoscopy, where a camera goes down the airways, or a needle biopsy, guided by CT. Sometimes surgery is needed to get a sample. The sample then goes to the lab for analysis, cytology, or histology to confirm cancer and determine the exact type.
And once you know it's cancer, and what type staging is next?
Exactly. Staging tells you how far the cancer has spread.
Mm-hmm.
For NSCLC, we use the T&M system tumor size, node involvement, metastasis. For SCLC, it's usually simpler. Limited stage, meaning confined to one side of the chest, or extensive stage, meaning it spread more widely.
And this involves a whole team.
Absolutely.
Yeah.
A multidisciplinary team, oncologists, surgeons, radiologists, pathologists, specialist nurses, they all work together.
Now, thinking about GPs in the UK, when should they be triggering an urgent referral? What are the NICE guidelines?
Right, the 2-week wait pathway. It's triggered for anyone aged 40 or over with unexplained hemoptysis. Or if a chest X-ray comes back suggesting lung cancer.
Okay.
Then you need an urgent chest X-ray, also within 2 weeks, for people aged 40 plus if they have 2 or more unexplained symptoms from a specific list.
Which includes?
Cough, fatigue, shortness of breath, chest pain, weight loss, or appetite loss.
Yeah.
Or if they have ever smoked and have just one of those symptoms.
Right.
Also, an urgent X-ray is needed for anyone over 40 with certain signs like persistent or recurrent chest infection, finger clubbing, swollen lymph nodes in the neck or above the clavicle, or persistent abnormal chest signs on examination.
That's clear. So once diagnosis and staging are done, what about treatment?
Treatment is highly personalized. It depends heavily on the type of lung cancer, the stage, the patient's overall health and fitness, and importantly, their own preferences.
What are the main tools in the toolbox?
The key options are surgery to physically remove the tumor, radiation therapy using high-energy rays, chemotherapy using drugs to kill cancer cells systemically, targeted therapy drugs aimed at specific molecular targets on the cancer cells.
Like those EGFR mutations you mentioned.
Exactly. And immunotherapy, which harnesses the patient's own immune system to fight the cancer. And crucially, palliative care should be considered right from the start, focusing on symptom control and quality of life, whatever the stage.
You mentioned surgery mainly for NSCLC.
Yes, for early-stage NSCLC, surgery offers the best chance of a cure. For more advanced NSCLC, it's often combinations of chemo, radiation, targeted therapy depending on the cancer's specific genetic makeup, and things like PD-L1 status for immunotherapy, or the immunotherapy itself. Surgery is rarely used for SCLC because it tends to have spread by the time it's found.
What about smoking?
Absolutely critical. For patients who smoke, stopping smoking significantly improves treatment outcomes and overall survival. It's never too late to quit.
Okay, let's talk about the outlook, the prognosis. What are we generally looking at?
Well, unfortunately, overall, the prognosis for lung cancer remains quite poor, particularly if it's diagnosed at a late stage.
But early detection helps.
Massively. If it's caught when still localized, confined to the lung, the 5-year survival rate is much better, maybe around 60%. But if it's spread to distant sites, metastatic disease, that 5-year survival drops dramatically, often below 10%.
Are things improving, though, with newer treatments?
Yes. Targeted therapies and immunotherapies have definitely improved outcomes for some groups of patients, which is offering more hope. But the overall picture is still challenging.
Do you have any UK-specific figures?
Yeah, looking at data from 2013-2017 in England, about 40.6% of patients survived for at least 1 year. The 5-year survival was around 16.2%, and the prediction for 10-year survival was about 9.5%.
Still quite sobering numbers.
They are. Interestingly, survival tends to be a bit better for females than males, and for patients diagnosed under 40. But overall progress in improving survival in the UK over the last, say, 40 years has been quite limited compared to some other cancers.
Which brings us back to prevention. If the prognosis is tough, stopping it starting seems vital.
Absolutely paramount. Given that over 80% of lung cancer deaths are linked to tobacco use, Primary prevention, stopping smoking, and preventing people from starting is by far the most effective strategy.
And other risks.
Reducing exposure to things like asbestos, radon, and air pollution is also important, of course.
Is there screening in the UK?
No national screening program currently. In the U.S., they do offer screening with low-dose CT scans for certain high-risk individuals, typically older adults, 55 to 80, with a significant smoking history, but not routinely here yet.
Okay, so let's try and pull that together, thinking high yield for exam prep. Key takeaways.
All right, lung cancer. Uncontrolled cell growth in the lungs. Smoking, the #1 cause by a huge margin. Two main types, NSCLC, more common, varied subtypes, and SCLC, more aggressive, often widespread at diagnosis.
Symptoms can be vague initially, so think red flags. Persistent cough, hemoptysis, weight loss, but also paraneoplastic syndromes. Diagnosis relies on imaging, CT, and crucially, biopsy.
Staging is key. TNM for NSCLC, limited extensive for SCLC. Management depends on type, stage, patient factors include surgery, radiotherapy, chemo, targeted therapy, immunotherapy. Palliative care is vital.
Prognosis generally poor, especially late stage, but early detection improves it significantly. Prevention focuses heavily on smoking cessation.
Exactly. You've got the core framework there. And remember, for more detailed, high-yield revision resources tailored for the MSRA, do check out pasthemsra.com and freemsra.com.
Great. It's a complex area, but hopefully this deep dive has given you a solid foundation. And research is always ongoing, bringing new developments in treatment all the time.